green, red.
Green, red.
Hello, everyone. Can you hear me?
Hi, Dr. Marco. Yes, we can hear you.
So let me just share my screen so that we see the presentation will be fine. Am I clear?
Yes, very clear. It's visible.
Can you see my presentation?
Yes, it's very visible.
All
Yes, you
right.
can. It's fine.
It's now on the PowerPoint, so it's okay?
Yes, it is. It
Okay,
is.
and then we said I won't put video because I think it's really breaking up with the video.
Okay, no problem.
So is it breaking up now as I'm talking?
No,
Okay,
not at
so.
all. It's even better than yesterday.
Oh, okay, that's good.
Mm.
So do I stop sharing so that you can introduce yourself?
We'll give people the 10 minutes until 6:30 so that we start at 6:30. So just stop sharing. Then
Yeah.
when I introduce you, then you'll reshare.
Okay, sawa.
Okay, thank you.
Okay. Okay, fine. Thank you.
Hi, good evening, everyone. My name is Dr. Idzakalu. Welcome to today's CME. Today we are going to be delving into matters glaucoma. And with us to moderate today is Dr. Wendy Njoya, a consultant ophthalmologist currently practicing at CTI Hospital, who's going to be introducing our speaker for today, Dr. Marco. Please remember to put your questions in the chat box, even as the presentation goes on, and they will be responded to at the end of the presentation. In case of any burning comments or contribution to the discussion, you can raise your hand with the icon, and then the moderator will make sure you get an opportunity, time allowing. Thank you very much. Karibu Daktari.
Good evening, everyone. I believe this will be the last CME of the year before we go for the OSK conference.
No,
So
we
as,
have one more.
Oh, we have one more. Oh, sorry. I thought
Yes, we have one more next week.
Ah, okay, fine. So today we are privileged to have Dr. Sheila Mako being with us. She has over 10 years experience as a glaucoma specialist based at the University of Nairobi and also at the Aga Khan University Hospital. And she is also the founder and medical director of the Iridian Eye Center. So today she'll be taking us through secondary glaucomas, mainly looking at neovascular glaucomas and traumatic glaucomas. So Dr. Mako, please, you can have the floor.
Thank you, everyone. And I'm very happy and privileged to join you once more. I'm going to just start sharing my screen. And thank you, Wendy, for that nice introduction. I'll have to put off my video because my connection is not very good. So you'll just hear my voice. So please let me know if my slides are clear so that we can start.
Very clear.
Okay, so as Wendy has said, I'm a glaucoma specialist at the University of Nairobi, also at Aga Khan and at Iridian Eye Center. And today I'm going to talk about secondary glaucoma. There's so much to cover in secondary glaucoma, but I've picked the most common cases that we come across on our day-to-day basis in our clinics and in our outpatient center facilities. So, okay. Okay, so by definition, secondary glaucoma refers to any form of glaucoma where there is an identifiable cause of the increased intraocular pressure, which results in optic nerve damage and visual loss. And it can be broadly divided into angle closure or open angle. It can be unilateral or bilateral. I won't go much into the different types, but just as a summary, I found this table in one of the books. So for the open angle secondary glaucoma, we have pigmentary glaucomas, pseudoexfoliation, increased episcleral venous pressure, steroid-induced, lens-induced, intraocular hemorrhage, post-Schlossman syndrome, intraocular tumors, blunt trauma, iatrogenic, and these are the ones that cause secondary open angle glaucoma. This list is not exhaustive, it's just a summary because there's quite a lot more that hasn't been mentioned. And for the closed angles, also tumors, uveitis, neovascular glaucoma, the eye syndrome, aniridia, aqueous misdirection, uveal effusion, post-argon laser trabeculoplasty, so phakic intraocular lenses. So there's so much that can cause the secondary angle closed glaucoma. This is just but a few. Today we're just going to look at the most common things that cases that we come across, or at least that I come across, and this is a neovascular glaucoma and traumatic glaucoma. It's just a recap. I think I've given these talks in the last couple of years. So it's just a recap of what we see and just a reminder of how we should handle these cases. So neovascular glaucoma, as we know, the iris and anterior chamber angle neovascularization can be associated with the increased intraocular pressure. And the main thing is that there's severe retinal ischemia. And in these cases, neovascular glaucoma, once you see a patient with neovascular glaucoma, blindness is almost imminent if you don't do anything immediately. So it's potentially a devastating disease where delay in diagnosis or poor management can result in blindness. The common causes that we usually see are the causes as the central retinal vein occlusion, branch retinal vein occlusion, and proliferative diabetic retinopathy, uveitis, vasculitis, carotid arterial obstruction. Sometimes we see this in ocular tumors, but there are so many other causes of retinal ischemia that I could not include all of them in this slide. But these are the most common causes that we see on the list to the to the left, but there are many other causes. The underlying element is that in whichever cause, whether it's vasculitis, retinal vein or retinal artery occlusion, there's retinal ischemia or hypoxia, and there's release of an angiogenesis factor, for example, VEGF, this is one of them, and there's new vessel growth or formation over the iris and the angle. So any of the causes we have mentioned in this slide and many other causes that I haven't mentioned eventually lead to new vessel formation over the iris and the angle. Now, it's very important to know how the neovascular glaucoma presents. It can present as a secondary open angle or a secondary angle closure. Ideally, you'd want to catch these cases at the secondary open angle case stage, because when you treat it aggressively, you'll be able to prevent the patient from progressing to the secondary angle closure. So in the secondary angle, in the secondary open angle, the new vessels of the iris may or may not come before the new vessels of the angle. So if you examine a patient who has PDR and you don't see any vessels on the iris, it does not necessarily mean that they don't have vessels already at the angle. Any patient who has proliferative diabetic retinopathy should have a gonioscopic examination, so that in case of any new vessels of the angle, in case the patient has new vessels at the angle, this can be picked quite early, because saying that the patient doesn't have rubiosis does not mean that they don't have new vessels of the angle. So in this case of the open angle, fibrovascular membranes, which sometimes are invisible on gonioscopy, they accompany the new vessels of the angle and progressively obstruct the trabecular meshwork. So this is the early stage. There is no pain, there are no symptoms. The IOPs are moderately elevated between the 20s and the 30s. And what I'm saying, you really need to do gonioscopy in these cases to pick up these new vessels at the angle. And for the treatment in this case is usually you put them on anti-glaucoma medication, and you do a very extensive panretinal photocoagulation and also inject anti-VEGF. So for the angle, for the closed angles, in these cases, the fibrovascular membrane that I had mentioned earlier, they tend to mature and contract and form peripheral anterior synechia and progressive angle closure. And these patients usually have also extropia and UVA. When the patient gets to this stage, the pressures are usually very high, and they present with pain, reduced vision, photophobia, headache, basically the signs that are usually associated with an acute angle closure. The pressures are usually very high, above 40. I've seen patients with presenting with pressures even in the 70s and 80s. Microcystic edema, they can have a mild anterior chamber reaction, extropia and UVA, rubiosis. On fundoscopy, if you're able to visualize, you might see neovascularization and glaucomatous optic atrophy if the patient has had this condition for a while. So how do we treat these patients? So first, you want to reduce pain and discomfort by mainly lowering the pressures. You can use any of the glaucoma medication, the beta blockers, alpha-2 agonists, topical or oral carbonic anhydrase inhibitors. We try and avoid the prostaglandin analogs and pilocarpine because they potentiate or make the inflammation worse, but sometimes we have no choice, especially we have to introduce the prostaglandin analogs, but try and avoid them initially. Also treat the patient with some cycloplegia, atropine or cyclopentolate, whichever you have, and topical steroids just to reduce the low-grade inflammation they have. Definitive treatment is panretinal photocoagulation and an anti-VEGF, and the retina team can confirm whether this is what they do, but we usually advocate that after PRP, they get an anti-VEGF injection if indicated. So in these patients, once they have the acute angle closure from the zipping up of the angle, that is when the angle is closed. Trabeculectomy, you can do it, but the success rate is very low. More than it will fail in more than 70% of the time. But if you have nothing else and this is how your patient presents, you might just have to do it though knowing it's going to fail. That is if you're not able to send the patient to a center where a glaucoma drainage device can be inserted. So definitively we prefer to put in a glaucoma drainage device. And if the patient is in pain and the eye is blind, we either give the retrobulbar, Lagactil or alcohol, or most of the times we do the cyclodistraction, the transscleral cyclophotocoagulation. Now, I just wanted to mention something about neovascular glaucoma post-cataract surgery, because sometimes patients, the patient is diabetic. Maybe you're not able to visualize the fundus. You don't know the extent of their diabetic retinopathy. And maybe you get complications during the surgery, maybe vitreous loss and the surgery is complicated. So in these cases, they have done studies and they have shown that if you do cataract surgery, they've compared phacoemulsification versus ECC or even small incision cataract surgery, and they have found that patients are much better off, for lack of a better word, when you use the phacoemulsification technique. Basically, what happens when you do cataract surgery, there is going to be a breach in the blood aqueous barrier. And once you breach the blood aqueous barrier, there is going to be a movement of the vasoendothelial, more movement of the vasoendothelial growth factors into the eye, and hence stimulating more of the angiogenesis. And they are found much more of this in the ECC stroke manual small incision versus the phacoemulsification. These are just studies that have been done. And in post-cataract surgery, if you think a patient is at a high risk of developing neovascularization at the angle, these are patients who usually have preoperative PDR. So if you're able to visualize the fundus prior to cataract surgery, please do an extensive PRP and ensure that the patient is safe and safe for cataract surgery after an extensive PRP. Because if they have PDR or absence or inadequate panretinal photocoagulation, or if you get a PC tear or you have a prolonged complicated cataract surgery, these are patients who are at a higher risk of developing neovascularization. And you can prevent this by doing, as I said, pre-op PRP, do phaco, it's better than ECC stroke, the manual small incision cataract surgery. Or sometimes you can do the phaco plus anti-VEGF. Or in some cases, if you can do the PRP intra-op or post-op plus anti-VEGF, these are going to help reduce the risk or prevent the neovascular glaucoma post-cataract surgery. So I've brought this here because sometimes patients have had cataract surgery uneventful, and they present 2 months or so later with a very extensive neovascular glaucoma, rubiosis, and maybe it's because they were not followed up adequately. So it's something to always consider. Also post-vitrectomy, and my VR colleagues can also contribute to this. There's an increased risk of developing neovascular glaucoma post-vitrectomy, especially if the patient has had pre-existing PDR, or the patient presents post-op with a retinal detachment, or there's inadequate PRP given during the vitrectomy or before or after. So these are things you need to take into consideration when a patient presents post-vitrectomy and they present with neovascular glaucoma. So I just have one clinical example, and this is because of time, others would have given several. So actually I just took a picture, so just don't worry about the handwriting. I just took a picture of the notes. So this is a patient who presented to me on 10th of December 2018, and she was referred specifically for CPC of the left eye because she had a painful blind eye. So both eyes she had received panretinal photocoagulation. The left eye she had received it a month earlier, but it went ahead to develop complications. And the panretinal photocoagulation had also been given on the right eye, and she had also received Avastin on the right eye, though she could not remember when. The left eye was very painful. She was not able to sleep. And when she came to me, she was already on Gangfort and Zolamol, which is really an overtreatment because Zolamol already has, Zolamol is a combination of timolol and dozolamide. Gangfort is timolol and bimatoprost. So she already was on like a double treatment for the timolol. So she had been diabetic and she was on insulin, and 1 week ago, her fasting blood sugar was 9.8. She was also hypertensive. Now, the main thing is that you note her visual acuity on the right eye was 6.9 partial, and the left eye was NPL. And the IOPs on the right eye were 23, and the left eye was 69. So on further examination, the right eye had open angles, the better eye that had 6.9, and she had, when I did the gonioscopy, she had a lot of new vessels at the angles and also new vessels on the iris. Fundoscopy, she had very few laser marks, CDR was 0.3, pressures were 23. So for this eye that really she hadn't been referred for the right eye, I referred her back to the retina surgeon for additional PRP plus or minus anti-VEGF according to his or her discretion, and to be put on anti-glaucoma medication and monitor the IOP for the right eye. The left eye had an acute angle closure because of the increased pressures. Remember, the pressures were 69. Conjunctiva was injected, microcystic edema, rubiosis, mid-dilated pupil, ectropia uvea. Pressures were 69, she was in pain, so we did the cyclophotocoagulation. Unfortunately, the patient did not go back to her retina, to the retina doctor who had referred her to me. And she came now in March 2020. This is almost a year plus, with a lot of pain on the right eye. And the vision was counting fingers 2 meters, microcystic edema, rubiosis, mid-dilated. So she did not go back for the retina team to continue the treatment, and hence developed now an acute attack. She developed neovascular glaucoma on her only eye. And now we had to give anti-VEGF and an AC tap to AC decompression at the same time. And then an AMED valve, we had to put in an AMED valve. Sorry, I forgot to write the pressures at this time were 54 on the right eye. The left eye that we had done the CPC, she was not in any pain. It was NPL, the pressures were 13. So in summary, neovascular glaucoma is a devastating condition, which is potentially blinding. Like in the patient we've seen, she had a very good visual acuity on the right eye, and yet because she was not able to follow the instructions, she lost the vision in that eye. Early diagnosis followed by aggressive treatment is mandatory. In an open angle, it's very good to give anti-VEGF and PRP and medical treatment to control the pressures, and this usually works. Yeah, and sometimes even when you give the PRP and anti-VEGF, the new vessels regress and the pressures come down, and you can actually stop the anti-glaucoma medication. But you really have to follow this patient up closely, and the PRP has to be very, very, it has to be adequate. But once you have the synechia closing, you have to, whether you give, whether you do PRP or not, once the synechia once the angle is completely closed, surgery is indicated. And mainly we do the AMED valves or the other glaucoma drainage devices according to what you've been trained to do, because trabeculectomy has a very high risk of failure. And in this patient, you still have to postoperatively follow them up to ensure a good outcome. So I think I'll just take questions at the end because I know neovascular glaucoma it's a condition that we need to manage quite aggressively. So I'll take questions at the end. And because of time, I'll just move on to the traumatic glaucomas. So traumatic glaucoma, I'm not going to go into a lot of the many of the different types, but I want to talk mainly about the closed globe injuries because these are the ones that are easily missed. So glaucoma after closed globe injury may go undiagnosed for many years. Yeah, and the patient can actually present with very advanced glaucoma many years after the initial injury. This means you have to take a very good history. If you find a patient has a unilateral glaucoma, it's a young person, you think it's a case that maybe may have been as a result of trauma. So they've done studies and they have found that usually after trauma, there are two peak incidences, incidences, mainly at below 1 year, and then 10 years, after 10 years of the trauma. So that means basically, if you have a patient who's had closed globe injury, you have to really follow them up literally for life, because the first peak is within the first year of the trauma, second peak 10 years after the trauma. So studies have shown that there's a 3.4% incidence of glaucoma after ocular trauma during the first 6 months. And this actually triples to 10% after 10 years after the trauma. So it's something that we need to take into consideration. You have to follow up the patient for life. So closed globe injury most commonly is as a result of hyphema, red cell glaucoma, and angle recession glaucoma. Others are lens-related glaucoma, ghost cell glaucoma, hemolytic glaucoma, and Schwartz-Motsu syndrome. We'll quickly look at the last four, then we'll come back to the hyphema and the angle recession, because as I said, these are the ones that are not obvious and are easily missed and can develop, end up developing glaucoma even 10 years later. So for the lens-related glaucoma, at least this one is quite obvious. A patient comes with the pupillary block because of this lens that is in the AC, you just remove it. You also have the lens particle glaucoma as a result of a ruptured lens capsule, either because of cataract surgery or trauma, and the lens particles physically block the trabecular meshwork and increase the pressure. Other lens-related glaucoma, we have the phacoantigenic or phacoanaphylaxis. So in this case, the lens capsulus is also ruptured, either post-surgery or post-traumatic, and there's a lot of granulomatous inflammatory reaction against the lens antigens, leading to increased intraocular pressure. So in this case, there's quite a lot of anterior segment, anterior chamber reaction. You'll see KPs, posterior senechiae, and it can occur up to 14 days after the trauma. Phacomorphic glaucoma also is a glaucoma that is associated with an intumescent lens post-trauma, and the patient presents with also pupillary block and very high pressures. Other cases are the ghost cell glaucoma, where you have the red blood cells that have, as a result of trauma, you get a vitreous hemorrhage, and the red blood cells that have lost their intracellular hemoglobin, they actually move into the anterior chamber and block the trabecular meshwork, and can occur 1 to 3 months after the vitreous hemorrhage. On the other hand, you can also have what is called hemolytic glaucoma, where the hemoglobin-laden macrophages are the ones that are found in the anterior chamber, and these block the trabecular meshwork. They present, you'll see some red tinged cells floating in the AC. Posterior segment, you have the Schwartz-Motsu syndrome. If the patient has had a retinal tear, post-traumatic, the photoreceptor segment, outer segments migrate to the anterior chamber and block the trabecular meshwork. So that was just a summary of the other kinds of glaucoma that can result, but we're going to now focus more on the hyphema and angle recession. So there was a study that was done in India, and this was published in 2008, where they wanted to find out patients who have closed globe injury, what factors or what risk factors did the ones who develop glaucoma have? So they gathered data from 92 patients, 52 who had closed globe injury, 52 did not develop glaucoma, and they followed these patients over 6 months. 52 did not develop glaucoma, and 42 of those developed glaucoma. Interesting to note, most of the patients had cricket ball or firecrackers injury because this was in India, obviously. But what I want to highlight are the factors that they concluded were associated with development of glaucoma. So one of the things is that if the patient presents with a reduced visual acuity of less than 660, you're more at risk of developing glaucoma, and a very high pressure at baseline, you're more at risk of developing glaucoma. Also, if you had a hyphema, and also if you had on gonioscopy, trabecular pigmentation of more than 3, you are more at risk of developing glaucoma, and an angle recession of more than 180 and even more than of up to 360, you are more at risk. And if the patient also had phacodynesis, you are more at risk of developing glaucoma. So this is very important so that you know when a patient presents with a closed globe injury, if you see a hyphema, if their pressures are very high, if their visual acuity is quite affected, if they have a angle recession or a dark trabecular mesh-shock pigmentation, or even phacodynesis, then they are at a higher risk of developing glaucoma, and you have to follow these patients up closely. Now, just to look at hyphema, so we know that we can grade hyphema from grade 1 to 4, and grade 1 and 2 are the most common presentations of hyphema. Grade 1 being less than a third, 2 a third to a half, grade 3 being a third to less than the total anterior chamber, and grade 4 being the 100% of the blood in the anterior chamber. So, or it's usually referred to as black ball or 8-ball hyphema. Now, grade 3 and 4 are the most dangerous types of hyphema, because in these particular cases, the patients seem to be at a higher risk of presenting with rebleeds, and we'll look at that in this next slide. So in the early in the early hyphema period, the high pressures is mainly due to the trabecular mesh-shock being plagued by the red blood cells and fibrin. And most patients actually with a hyphema have a high intraocular pressure of more than 22. But the worst kind of hyphema is when you get the secondary hemorrhage, and this occurs in day 3 to 4, and it occurs in about a quarter of the patients. And but some studies say between 7 to 38%. But the secondary hemorrhage is as a result of lysis and retraction of the initial clots and fibrin that have occluded a traumatized vessel. So initially when the hyphema occurs, there's a clot that forms and occludes the vessels. But when secondary hemorrhage happens is when the clot starts undergoing lysis, and then there's a secondary bleed. And the problem with this secondary bleed, it can result in very high pressures, corneal staining, and it's associated with poorer visual prognosis. And the incidence is higher in the grade 3 to 4 hyphemas. That's what I'm saying. That's what I had said. We have to really keep an eye on the grade 3 to 4 hyphemas, because the risk of secondary hemorrhage is higher in those patients. Other complications of hyphema that can lead to glaucoma in the long term are posterior synechia secondary to the inflammation, iritis or iridocyclitis, and also they can develop peripheral anterior synechia, whereby, especially if the hyphema has been in the eye for longer than 9 days, the patient is at more risk of developing peripheral anterior synechia, and both cases can lead to very high pressures. Apart from high pressures, when you have a hyphema, a patient who has had a very, very high pressures within a short time, they can actually develop what is called diffuse optic disc pallor. And it's not a glaucomatous disc. When you look at this disc, it just looks like a pale disc. It doesn't have the typical capping and increased cap to disc ratio and bionating and nasal shifting of vessels. So in these patients, what happens is that there's transient periods of very marked elevated intraocular pressures where the patient can have constant pressures of 50 or more for 5 days or 35 or more for 7 days. So the cause of the optic atrophy is actually ischemia. There's an acute ischemic process to the optic nerve. And you'll find that in these cases, even when you lower the pressures and you follow up the patient with some time, after some time, they present with a primary optic atrophy, and it's not glaucomatous. So we have to be careful about this, because when patients are having very, very, very high pressures acutely over a short period of time, they can actually get blind if you do not intervene early. Another thing that can cause permanent blindness or reduced vision is if you have a corneal endothelial blood staining, and this is mainly in hyphemas that have been there for 6 days with IOPs of greater than 25 millimeters of mercury. Okay, so how do we treat hyphemas? So just basically avoid aspirin and NSAIDs. Usually we prefer to just give paracetamol. You can patch or shield to protect the eye, elevate the head so that when sleeping or resting, so that the level can be, the hyphema level can be found. And we also try and put them, it's also very important to put them on cycloplegics and corticosteroids, put them on anti-glaucoma medication, and to prevent the incidence of secondary hemorrhage. Usually you can give the patient antifibrinolytics. Most of the times we have tranexamic acid, so that you prevent to decrease the incidence of secondary hemorrhage, especially in grade 3 to 4 hyphemas. Some people give intracameral or topical TPA in patients with persistent hyphemas. But in my opinion, really, by the time a patient has persistent hyphema, you should be rushing this patient to theater and not injecting them with this intracameral TPA. So anyway, surgery. When do you take them to surgery? Anytime a patient presents with corneal blood staining, total hyphema with pressures of 50 or more for 4 days. But usually I try not to wait for the 4 days, especially if you've had persistently high pressures and you have a total hyphema that is not resolving. Because even the high pressures are more, you're at a higher risk of developing corneal endothelial staining. So also they say that, this is now from the literature, if you have a hyphema that's more than 3/4 of the anterior chamber for more than 6 days, pressures of 25, take the patient to theater, or more than 50%. So there are all these guidelines that they give, but I think as a clinician, you should assess your patient and decide, am I going to take this patient now or am I going to wait? So if you start the patient on treatment, you elevate the head, you see the hyphema level is coming down, the pressures are coming down, the corneas are getting clear, the eye is improving, you don't really need to take this patient to theater. But after 2 or 3 days, if you find it's just persistently, the pressures are high, the hyphema is persistent, or even there's a rebleed, it's better to take that patient for anterior chamber washout. Obviously, patients who have sickle cell disease, these are patients you don't want to wait too long, because you have to take them earlier. And also children have to be taken in earlier for an anterior chamber washout. So quickly now, as a final condition, we'll look at angle recession. So angle recession can develop within months or even years after the initial injury. So we are talking about 50 years after even the initial injury. And up to 60% of eyes with a blunt eye trauma will develop some degree of angle recession, just some degree. But if a patient has had a traumatic hyphema, angle recession is almost always present. Up to 60 to 100% of patients will actually develop an angle recession if you've had a hyphema. And they found about 4% of patients will develop angle recession glaucoma at 6 months. But there's some study that was done, and they showed that 10 years after the initial injury, for some of these patients, 6%, almost double, 6% of the patients developed angle recession later on. So the main thing with the patients, as I said initially, patients who've had closed globe injury, you have to really follow up these patients for life, even if it's once a year, just to follow them up and make sure they're okay. So I go back to this earlier study, and what I want to just highlight is that one of the factors that was strongly associated with developing glaucoma is an angle recession. And others have reported varying amounts from 180 to 240 degrees, but most studies have confirmed that anything greater than 180 degrees of angle recession makes glaucoma more likely. So really you have to do a gonioscopy on these patients and follow them up. So what is this angle recession? So when you do your gonioscopy, you'll find that the patient has a very, very wide ciliary body band. And what happens initially is that the blunt forces causes, there's a tear between the longitudinal and the circular muscles of the ciliary body. And there's damage to the ciliary arteries at this level. And this is what initially leads to the hyphema. Okay, and then after the hyphema clears, there's also as a result of that initial impact, there's also damage to the trabecular meshwork, yeah, from the initial impact and the Schlemm's canal. So the pressures can actually rise because even the trabecular meshwork gets edematous, there's inflammation, there's blockage even by blood if there's a hyphema. But what causes really the long-term increase in IOPs is that there's scarring and fibrosis of the trabecular meshwork and the Schlemm's canal. And this can come much later on in life. And this is what leads to the elevated intraocular pressure. So how do we treat these patients? So medical therapy can work, where you put them on topical aqueous suppressants, timolol, carbonic anhydrase inhibitors. We usually try and avoid the prostaglandin analogs, especially in the acute phases of the trauma, because of their they can make the inflammation worse. And also pilocarpine should be completely avoided, as it can be has been reported to make the angle recession worse. Surgical treatment, you do not do laser trabeculoplasty in these patients because their trabecular meshwork is already scarred. You can actually do a trabeculectomy with mitomycin C. It has been quite successful in lowering the pressures, though there could be a high risk of failure. And I have to say, most of the patients that we have done the trabeculectomy with mitomycin C, hello, can you hear me?
Yes, we can still hear you.
Okay, so there's been a blackout, so I'm not sure how long I'll survive. Okay, so can you still hear me? Fine.
Yes, we can.
Yes.
Most of the patients who've had a trabeculectomy, the mitomycin C, this has been quite successful. Otherwise, we also do the glaucoma drainage devices and the cyclodestructive procedures when the visual potential is very poor. So this is a 31-year-old male who presented with reduced vision and occasional discomfort and a dull ache on his eye. His visual acuity was 624. Van Herrick was a very deep anterior chamber, 2 corneal thicknesses. On gonioscopy, he had an angle recession of 280 degrees, normal lens, high intraocular pressures. He did not recall any trauma, but his mother confirms he had an injury while playing sports at 10 years of age. We treated him with eye drops and eventually did a trabeculectomy with the mitomycin C. So in summary, glaucoma after closed globe injury is a major concern. It might go undiagnosed for many years and eventually present as an advanced glaucomatous neuropathy. Early predictors of glaucoma in post-traumatic cases include reduced visual acuity, very high pressures, increased trabecular pigmentation, widened angle, and phacodynesis. Aggressive treatment of the hyphema can reduce risk of post-traumatic glaucoma, and surgical management of angle recession is recommended. So I think I'm done with my slides. I'm happy to take any questions.
So thank you, Dr. Marco, for a very comprehensive summary of the secondary glaucomas. So far, we just have a few questions. I'll start with the first one from Dr. Amos Kibata. He's querying the science behind why phacoemulsification is deemed to be better than small incision cataract surgery in patients who are at risk of neovascular glaucoma.
Okay, so what the studies have shown is that what happens is that when you have a lot of increased blood aqueous barrier from whichever intraocular surgery, when you have more disturbance, so to speak, of the blood aqueous barrier, then that means a lot of the anti-VEGF is being produced, not really produced, like spilled into the eye, for lack of a better word. So the more the disturbance of the blood aqueous barrier, the more not the anti-VEGF, the more the VEGF, the vasoendothelial growth factors are being spilled into the eye, and the more risk of the patient developing neovascularization. That's what I understood from those studies. But if the patient, of course, has no other option and you have to do the manual small incision, better to do an extensive PRP if you can visualize the fundus before, or you do a manual small incision and plan for a PRP immediately after, or combine it with the anti-VEGF injection.
So another question would be, now still on neovascular glaucoma, what would you consider as a visual acuity cutoff when considering whether or not a patient is a candidate for a glaucoma drainage device, considering that they might have very severe corneal edema, which might be contributing to the poor vision? So when do you decide to go for the device, or decide it is too late?
That's a very good question. It's actually quite difficult sometimes when they present with the very high pressures and the corneal edema, and the vision is quite reduced. So most of that, obviously, if it's NPL, I'm not going to do a glaucoma drainage device. And even PL, and also look at the state of the pupillary reaction. So even PL and the pupil is amaurotic, I won't do. Hand movement or any navigational vision, I would consider, because sometimes their eyesight actually improves once the pressures come down and the cornea is clear. And sometimes even those very, very high pressures, there's so much ischemia, like a mechanical ischemia on the optic nerve. So once you relieve that pressure, once you relieve that pressure, even on the optic nerve, their vision actually improves. So if the patient has navigational vision, that one I would do a glaucoma drainage device. If the patient has some hand movement and the doctor has sent them immediately, and the retina doctor or the primary doctor has sent the patient and said, last week this patient was 660, today their hand movement, that one I would do. But PL and NPL, I most likely would advocate more for the cyclophotocoagulation. In some of these patients, what I usually do, I give them a trial of very, very high, if there's no contraindication, very, very high carbonic anhydrase. I put them on Diamox QID for like 3 days or 4 days, and tell them to come when they're on Diamox, so that I have a look when the corneas have cleared and see what the visual acuity is. Because if the cornea clears and their pressures have come down from 70 to about 20 and their vision has sort of improved, then you'll go ahead and do. But if they still come back and they're still PL or NPL, then I wouldn't put in a glaucoma drainage device. So it's tricky because some patients come and they're NPL and they've been referred for glaucoma drainage device and you tell them no. So my cutoff really is navigational vision, that one I'll give. Hand movement that is sudden, you know, maybe their vision was quite good a week or so before, but PL and NPL, it's a bit tricky. I would most likely do a CPC for those.
Another question is about the time interval between giving the anti-VEGF and doing the glaucoma drainage device surgery. What time interval do you give before?
48 hours to up to 1 week. And usually I ask the doctors giving the anti-VEGF to do an AC tap, AC decompression, to just decompress the eye a little bit, because once you give an anti-VEGF, the pressures even go higher. So if the patient is being seen on a Monday by the primary physician, doctor, whether it's a retina surgeon or any other doctor who has seen the patient, I will do the surgery on Wednesday or Friday, or any from 48 hours is good enough, 48 hours to 1 week. So I don't wait too long, but you know, sometimes because the patient has to travel up to a week, but 48 hours is good enough. Because actually, so I want to just highlight a little bit more. I cannot put a glaucoma drainage device if the patient has not had an anti-VEGF injection. Reason being, where you're going to put in the tube, there's a lot of new vessels at the angle, new vessels at the iris. And when you put in that tube, when the patient still has a lot of blood vessels, they're going to get traumatized and they'll bleed and they'll form a clot and they'll form a hyphema that you will not be able to control, and the pressures will still be very, very, very high. So I usually do not touch an eye that has not had an anti-VEGF injection, simply because you're going to run into a lot more problems. So anti-VEGF is actually mandatory to be given before any glaucoma drainage device in a patient who's had neovascular glaucoma.
So Dr. Gohil shares some of his experience. He says that he feels that total bed rest is very important in the management of the hyphemas, in addition to the medication that you have mentioned. Then Dr. Kibata asks about what is your view on cyclophotocoagulation as a primary glaucoma treatment? I think this might be aside from the secondary glaucomas, just CPC as in general.
I don't have experience with our normal CPC. Our CPCs are very destructive. There's a lot of, you know, we wait for the ciliary processes to pop, you know, to know that we are adequately giving pressures. We are adequately doing adequate CPC. So a ciliary process popping, meaning it's exploding. So there's a lot of inflammation, and I really have no experience in seeing eyes, though there's a lot of literature and a lot of studies that have shown you can do it as primary glaucoma treatment. However, the micropulse cyclophotocoagulation is a different kind of transcleral laser photocoagulation that has been used. So the micropulse uses much lower controlled laser, and it ablates the ciliary body such that the pressures are adequately lowered. And this is, they have said is a safer procedure. But for the G probes that we usually use, I'm not really comfortable in seeing eyes, but other surgeons have used it and have said it's very effective. But for me, I'm more worried about the side effects of inflammation, macular edema, cataract, hyphema. There's a lot of side effects in this patient. So I don't use it primarily, but some people actually do. But the micropulse, which is a different kind of laser, still from the same company, Iridex, they actually use it. They say it's very good for primary treatment of glaucoma. Maybe one of the other glaucoma guys on the, if there's anyone else who has experience with the normal cyclophotocoagulation G-probe, maybe they can give the experience, but for me, I don't use it in seeing eyes.
So for yourself, Dr. Mako, do you have any experience with the MicroPulse CPC?
I don't, because it's a very expensive machine and the probes are very expensive, but I think there's a machine in Tenwek. So, and I think they have been using it there. So maybe they can maybe give us their experience.
I don't know whether there's anyone in the meeting today from Tenwek. Maybe not, no one seems to be coming forward. So another question, how do you assess intraocular pressure in an edematous cornea with pseudophakic bullous keratopathy?
It's tricky because what I usually do if there's pseudophakic, I use the eye care. Yeah, it may not give. Hello, it might not give very accurate readings, but if the pressures are high, then they're high. So I usually use the eye care because you cannot applanate an eye that has pseudophakic. It's very difficult to applanate an eye that has pseudophakic bullous keratopathy. So I use the eye care, and I guess you can use the air puff or the tonopen, but applanation can be quite tricky.
Going back to the neovascular glaucoma, is it possible when it's still at the open angle stage for the IOPs to be so high and cause a hazy cornea that might prevent a PRP to be done?
Okay, probably the retina guys can help me out there because I don't see the neovascular glaucomas that early. You know, these are patients who are usually on follow-up in the retina clinic. But usually when the angles are still open, the pressures are between 20s and 30s where the cornea is still relatively clear. So most of the times you're able to do a more extensive PRP, like in the case I had given my patient. You know, you're able to see the fundus pretty well and you're able to do a PRP. So maybe the retina guys can contribute there. I think in my little experience, most of the patients who present with very hazy corneas, microcystic edema and all, the pressures are late 30s and 40s, and that's when the cornea gets pretty hazy. But 20s to 30s, it's still, the visibility is still pretty good. I don't know, maybe the retina guys can give their opinion.
Hi, this is Mushai, one of the retina people. Yeah, I agree with Dr. Mako. In those earlier phases, when you find there's that iris neovascularization, and even in the iris, as long as you have a clear cornea, we'll do as much PRP as you can because it's still quite clear. Actually, IOPs of 30, you have a pretty decent view of your retina, and you'll do as extensive a PRP as is possible, and then immediately refer for glaucoma review. In cases where we don't have a view, then we do the Avastin injection so that then there's less vascularization and therefore less, Hyphema at the time of tube installation. So I agree. If you can do a PRP, take advantage and do it then. If you postpone it by a week, you might have lost that opportunity. So do it same day if possible.
Thank you, Dr. Mushai, for your input. Another question now, for you said trabeculectomies don't really work well for patients with neovascular glaucoma, but sometimes our clients are very fine in the periphery, and maybe there's that, that likely delay coming to Nairobi to get the glaucoma drainage devices. So for our colleagues who might be a bit farther away from Nairobi, would you advocate for them maybe doing an anti-VEGF before doing the trab as a stopgap, then maybe still send the patient for the glaucoma drainage device?
So as I said, the trabeculectomies have a very high failure rate in these patients because they usually fail anyway. Less than 30% survive. So if the patient is really, really far and you have nothing else, you're not able to send them to a center where a glaucoma drainage device can be put. And they're being put in many centers, by the way. In the coast, we have Korir, you have you have Professor Kiage, Kisi in Nairobi. There are quite a few centers where they're put. But in case for some reason the patient is unable to travel to any of those centers, then it's okay. Put the patient on anti-VEGF and do because you also don't want to do a trabeculectomy when you have new vessels of the iris. You know, when you do that PA, there's going to be some intractable bleeding. So if really you have nothing else to offer that patient, then it's okay. Do the anti-VEGF, wait 48 hours or so, and do the trabeculectomy. However, you have to use mitomycin C. And number two, the patient's pressures have to be controlled before you do the trabeculectomy. Because if you go in to do a trabeculectomy when the pressures are in the 70s, you're going to get a very bad complications, suprachoroidal hemorrhage, and all sorts of things that you don't want to, to deal with, because trabeculectomy really drops the pressures down. So there are certain precautions that you should take. Like if you can bring the pressures down to the 20s or maybe early 30s, then go ahead and do the trabeculectomy, but use mitomycin C. But as I said, try and control the pressures pre-op. And then refer the patients once they are stable. If you think they are, if you follow them up and feel they still need the glaucoma drainage device.
Okay, I think we're done. I can't see any other questions. So unless you have any closing comments, I'll hand over the meeting back to Dr. Kalu.
Thank you, Dr. Njoya. Thank you, Dr. Marco, for that enlightening presentation. It was a wonderful presentation and discussion. I will ask that you give us a few more minutes of your time so that we give the Novartis, our sponsor for today, a listening ear to what they have for us, even as they have supported our CME today evening. Gilbert Korir, kindly share your slides and presentation. Thank you.
I don't know if my presentation is on screen.
Yes, it is on screen and you are audible. You can go ahead.
Thank you very much. So thank you for this opportunity just to share one of our portfolio when it comes to glaucoma. So my name is Gilbert Korir. I'm a medical representative from Novartis. And today I'm going to share a very short presentation on Simbrinza suspension. So basically, this is our new portfolio on board when it comes to the glaucoma combination. So basically, what entails Simbrinza is it's indicated for the IOP, the decrease in intraocular pressure in adult patients with open glaucoma or even ocular hypertension, for whom monotherapy provides insufficient IOP reduction. So basically, it's used as an adjunct to PGS. In terms of what it contains 1% of brinzolamide and 0.2% of brimonidine. So basically it is azopt and brimonidine. So in terms of preservative, we have very low concentration of BAK, which is 0.003%, and the pH is approximately 6.35. So when it comes to the individual molecules, as you know, brinzolamide, which is the azopt we have, it decreases the aqueous humor formation. And brimonidine has dual mode of action in terms of suppressing the aqueous humor and also increasing the outflow. So you can see the synergistic effect of these two molecules. So brinzolamide, which is also a component of Simbrinza, has been proven to have nocturnal efficacy. So treatment possibilities for this molecule is basically as an add-on, as I've said, to PGA, for whom monotherapy provides insufficient IOP control. So we have this ANG study, which was just doing the fixed combination versus the individual components. So here we are talking of Simbrinza versus brinzolamide and brimonidine. So this study was done over a period of 6 months. So initially there was a washout period of 36 days, and the patients were randomized to either brinzolamide, brimonidine, and other patients were randomized to Simbrinza, which is the combination. So this was a double-masked randomized study, and inclusion-exclusion criteria were consistent with the previously published studies. So efficacy, the IOP efficacy was the primary endpoint for study 1. So the dosing was done at 9 a.m. and also 9 p.m. But in terms of the IOP measurements, it was done at 9 a.m., 11, and 4 p.m. So the mean IOP at week 2, 6, and month 6 average across all the time points. So this is just a chart which is showing. So basically what I want to point out is basically in terms of efficacy, there was a reduction of 7.7 millimeter of mercury on the lower side and up to 9.5 millimeters of mercury. So in terms of the percentage IOP reduction, it was from 28.1% to a maximum of 36%. That is from the baseline. So in summary, when more IOP is needed, we have Simbrinza. As I've said, it's brinzolamide 1% and brimonidine 0.2%. So in terms of the reduction of IOP, that's from 27 to 37. This is also shows that Simbrinza has consistent 24-hour IOP lowering coverage, and there are no additional risks which were identified with this when you compare with the individual molecules, that is brinzolamide and brimonidine. So this gives you a different way to lower IOP, which is combining an carbonic anhydrase inhibitor and alpha adrenergic agonist for dual mechanism of action. As you know, most of the combination in the market, you always have timolol and something else. So I'm sure this will give you more options of managing your glaucoma patients. So finally, that is, we've just added Simbrinza to a huge portfolio. That is Travatan, Azov, Bitoptic, Diotrav, Azaga. So we hope this is giving you now multiple opportunities to manage your patients. Thank you very much for your time.
Thank you very much, Gilbert, for your very short and precise presentation. And thank you also for sponsoring us today and allowing us to have this meeting and learn more so that we can also take care of our patients, even giving them better management that is evidence-based. Before we call this meeting off, I have a few announcements. So I would like to remind us about the OSK conference that is coming soon, end of November. Registration is ongoing. Abstract submission is still ongoing. So far, we have like 50 abstracts. So we thank you for those of you who have sent in your abstracts, and those who are yet to send in, please do so that we can learn from your experiences and your research. Also, register. We still are open for registration. Currently, we have had a good number of registration. We are at like 80 plus people. So come so that we will all gather together and share knowledge, even as we catch up a bit physically. I would also like to remind us that we have the AOC, the first AOC conference coming soon next week on Friday and Saturday. This one will be virtual. Please register if you have not yet registered. Plan to attend. There is quite an interesting features and articles that we can all learn from. Finally, we're going to have a last final CME for this year next week, Thursday. It will be in anterior segment discussion. So please plan to attend so that we can close this
Hello.
CME.
Mkubwa.
Gilbert, you are still on. Yeah, so that we can close our CME calendar with a bang and give ourselves some time to prepare for the OSK conference in November. So please plan to attend next week also. Details will be coming to you in due course. Thank you everyone for coming to the presentation today. Thank you, Dr. Marco, for a wonderful presentation. There are several comments about having had an awesome presentation. So thank you, Dr. Njoya, for moderating for us. Gilbert, on behalf of Novartis, give them our thanks for facilitating today's CME. And thank you everyone for coming. So see you here next week, same time. The topic and the presenter will be shared in due course. Have a good evening. Please feel free to leave the meeting. Thank you.